We wish to welcome you all, and we will start in a few minutes' time. As you come on board, please note that in the chat, we'd invite you to place your name, your position, and what organization and country you're from. That would be great, and we'll start shortly. So again, welcome. My name's Andrew Brown. I'm going to be your moderator for today. I would like to invite you as you come on in the chat to type your name and your position, your organization, and what country you're from. And we have a really global audience today. We'll start in a minute or two as people come on deck. Alicia, I think you may need to change people around to be seen for everybody else as we move along. I'll leave that up to you. And just to note to the interpreters as you get settled that I had chosen the English channel, but I was hearing French. So as we just get settled with those logistics. So welcome Bashir from Nigeria, and Ndimberu, welcome. And we have Ethiopia online and Malawi. Again, as you're coming online, welcome everyone. I would encourage you to mute yourselves and welcome you to the National Pharmaceutical Services Unit's webinar, A Critical Component for Medicines Availability and Use. My name's Andrew Brown and I'm going to be your facilitator. Please, as you come online in the chat, please type your name, your position, which organization you work for, and what country you're coming from. I'm coming to you today from Australia, where it's already Wednesday. So happy Wednesday to all of you, and great. Okay, so as you're coming on, thank you so much. I think we shall start, obviously, with people moving between meetings. People will start to come on, and we will gain in the numbers that we have today. First of all, I'd like to hand over to Alicia, who's going to just remind us of the logistics associated with webinar. Alicia, next slide, and the floor is yours. Thank you.
Good afternoon, good evening, and good morning, everybody. I'll be managing the Zoom function of this webinar. Just some housekeeping. Please mute your microphone if you're not speaking. Please feel free to use the chat box to enter any questions. We'll be monitoring that regularly. And note that this session is being recorded. Lastly, and most importantly, this webinar will be in both English and in French. So please choose your language settings on the bottom of the Zoom page. You can choose the globe icon, and you'll be able to hear simultaneous interpretation in the language of your choice. Thank you.
And as long as you choose English or French, that would be excellent. If you need Russian or Spanish, I'm sorry, we've not been able to have that interpreting service for you today. So again, it is my privilege to welcome you all here to this particular webinar. Webinar number 2 in the series of Resilient Pharmaceutical Systems for Better Health, brought to you by the USAID Medicines, Technologies and Pharmaceutical Services Program, MTaPS. Next slide, please. In our next 90 minutes together, we're going to go on a journey of discovery and end up with application. We're going to be thinking about National Pharmaceutical Services Units, about some of the global issues around governance, some definitions, and why is this something we should be addressing if we want to improve availability of medicines. Then we're very privileged to have experts from both Kenya and Côte d'Ivoire to present their contexts as case studies. We're going to go into a bit more detail with a group panel discussion, and then we're going to close out by having some guidance that as MTaPS we've prepared based on the case studies we've undertaken, surveys and literature work. And as we leave today, we hope that you will be better equipped with an understanding of National Pharmaceutical Services Units and a drive to help improve the governance of these most important units in country contexts for medicines availability. So let's go on this journey together. Next slide, please. Within MTaPS, the diagram that's being shown is our pharmaceutical system strengthening model. There's a range of research and publications about this particular model. But what I want you to notice is on the left-hand side, like most models of this type, we think about analysis and understanding the local context. And on the right-hand side, we're moving towards improved coverage of access of evidence-based interventions, particularly around medicines and medical technologies in pharmaceutical systems. Now, in the middle there is a flower, of which the center is medical products. And around the outside, you'll see human resources, information, financing, and service delivery. The leaf that we're focusing on today is that of governance, and understanding that governance led by and stewarded by ministries of health and perhaps other ministries in a government context are vitally important as an overarching feature within pharmaceutical system strengthening. And this is where we're going to be focusing today. Next slide, please. Another way of thinking about that through MTaPS is a slide we'll show you just in a moment, but MTaPS itself is a project that's been going now in its 6 years. We're working in 19 countries and we have offices in 19 countries and been working across 25 countries. And those icons on the screen tell you a little bit about the different areas that we've been involved with. And today we're focusing on governance. And if you'd like to find out more about our program and what we've been doing, please use your phone to scan the icon on the top right, the QR code, to access more information. Next slide, please. Now, we think about pharmaceutical systems in a couple of different ways, and I like this particular diagram, which we call the pharmaceutical systems pathway, to remind ourselves the journey that pharmaceuticals go on from when, at the beginning, they are developed through trials, and they move on through being approved and manufactured. The blue moves on to regulation and laboratory testing. There's market surveillance, and we move on through financing. The medicines become available in countries, and we have supply chain features such as quantification, procurement, storage, and distribution. But we know that health outcomes can only be changed if there are pharmaceutical services that look not only at availability, but also use. So we have prescribing, we have dispensing and sale, we have use, and we think about antimicrobial resistance or the use of antibiotics as a special use case, and then also pharmacovigilance or adverse drug reaction reporting. So through this pathway, we often think about 3 blocks. One of those blocks is pharmaceutical regulation. A second block is around about supply chain, and a third block is around pharmaceutical and pharmacy services. And it's in this context that we want to think about the governance, the national pharmaceutical services units, what's happening at the national level of governance to steward and to oversee these processes in country. Next slide, please. So to help us on that journey, we have the great pleasure of having Dr. Augustina with us, and she's from the head of pharmacy practice and clinical pharmacy at the University of Ghana. She's going to take a few minutes to help set the scene about the problem statement and some background activities that we've been doing. Augustina, the floor is yours. Thank you so much.
Thank you. Good morning, good afternoon, good evening, and greetings from the University of Ghana in Accra. Next slide, please. Okay. So as already mentioned by Andrew, we in the study looked at National Pharmaceutical Service Unit, and this we broadly defined as a division, a department, or directorate, usually responsible for medicine regulation, health supply chain, pharmaceutical service, or pharmaceutical practice, and in country. So we are thinking that in specific cases in country, everything is context specific. And these units are being influenced by political, constitutional, and administrative frameworks. These frameworks, political, constitutional, administrative, impact on the mandates and roles of these national pharmaceutical units. So in our study, we sought to examine the current functions, the mandates, and the typology of these national units. and recommend a minimal function, roles, and structures that needs to be present in national health system. We also sought to examine context-specific barriers and facilitators to the functioning of these national pharmaceutical units. Next slide, please. So why is it important for us to even consider looking at governance at national units? We realize that over time, institutional capacity for important operational national level issues such as pharmaceutical policies, formulation. So formulation of policies such as standard treatment guidelines, medicine pricing strategies. So the formulation, overseeing of these policies has become a bit fragmented and in some cases abandoned. Again, if we look at the mandates, so the legal mandates that put these institutions into practice or guide their functioning, you also will realize that this has narrowed over a period of time, and there's less attention, for example, to the design and implementation of national medicines policies. Again, there's limited guidance on how these important national level pharmaceutical service units should be organized and how they should function. Again, how can they best implement or act upon the mandates that sets them up? So this is where the whole study is situated in. Next, please. So by way of methods and approaches, we used a case study approach with two primary sources of qualitative data. We had a literature review and also in-depth interviews. From our literature review, we gathered information relevant to the structure, roles, functions, mandates of national pharmaceutical service units, with focus on units that are responsible for medicine regulation, health supply chain management, pharmaceutical service, and pharmacy practice. So we analyzed legislative and policy documents. We also looked at Ministry of Health organogram. We looked at published papers, peer review papers. With the peer review papers, we focused on papers that describe the delivery of pharmaceutical services with emphasis on the structure, medicines regulation, health supply chain management, and pharmacy practice. So we searched through Google Scholar, we looked at PubMed, we also looked at some of the websites of selected ministries of health, the WHO, we also looked at USAID website and also the FIP. With the interviews, we focused on having a stakeholder analysis. So based on findings from our literature review and experience from in-country team in Kenya, Nepal, and Côte d'Ivoire, we were able to conduct a stakeholder analysis to guide us to purposively select our respondents. We conducted the interviews to gain in-depth understanding of the functions and mandates of these units, how they have evolved, changed over time in country, and how they relate to each other, so other national pharmaceutical service units and other institutions within the health sector. So we interviewed, our key informants include directors of the Ministry of Health, heads of pharmacy regulatory agencies, and of course, individuals with direct, a lot of knowledge on the mandates and functioning of these pharmaceutical units. The interviews were conducted between September 2022 to June 2023. Now, in terms of data analysis and validation, this is very important in the work that was done. The team used thematic analysis to map out the units, so national level pharmaceutical service units, their mandates and functions, From the literature review, we're able to develop a typology structure with the functions. And for the specific case studies, we have the names, their mandates, so the laws that regulate them and set them up to function, how they have changed over time. So it's very interesting, as you will see moving forward, how these units changed over time and how they function. And it's also very important to understand how they are able to communicate with other national pharmaceutical units to perform their duties. We also focused in country in the 3 case studies on the facilitators and barrier to how the units are able to function. Now, to validate the findings were presented to a technical working group. So we had a technical working group formed as part of the research, and this included representatives from the countries in which the studies were conducted. We also had representatives from WHO, Pharmaceutical Service Africa. We had Commonwealth Pharmacists Association representative, and this was chaired by MTaPS Senior Principal Technical Advisor. Now, during this validation, the findings were presented and members had the opportunity to ask questions. In some cases, we had to go back into the literature to see, to formulate and better understand how the pharmaceutical units function.
1 minute.
So on that note, I want to end here and over to you, Andrew. Thank you.
Augustina, perfect timing. And you're sort of setting that academic scene about the where we've come from, but we haven't shared our results yet. We want you to be somewhat anticipating. So now let's do that. Next slide, please. What we've got for you today is special treats. We have 2 presentations, one from Kenya and then one from Côte d'Ivoire. And each of those presentations will give you a snapshot of these particular case studies before we look in these details in a bit more detail. Firstly, it's my great pleasure to introduce to you Dr. Tom Menenge, the Chief Pharmacist and Head, Director of Health Products and Technologies, the State Department of Medical Services, Ministry of Health, Kenya. And he's going to give an overview of the Kenya case study for you. Dr. Menenge, the floor is yours. Thank you so much.
Thank you very much, Andrew, and thank you, Agustina, for laying context for the discussion that we shall have today. I just go straight ahead and give the context under which we offer health services in this country. About 10 years ago, we decided to offer medical services or all health services using a county-based model and a devolved governance system, which means that there are 47 counties in this country, and the counties are coordinated from the national level, for which I take responsibility. We've also been on the forefront of adopting a universal health coverage, sort of like to ensure that all the issues of health are available in an affordable way and with quality. What has guided us over the years is a very key document that was passed by government in 2012 that we call the Kenya National Pharmaceutical Policy. And whereas it reads the Kenya National Pharmaceutical Policy, it actually covers all other health products and technologies that are used within the healthcare setting. We set out various objectives on the issues of availability of safe and effective essential medicine and medical supplies in the public sector. We also wished to address the issues of institutional, technical, and human resource capacity so that we can be able to offer effective pharmaceutical services. And also the Kenya National Pharmaceutical Policy hoped to enhance transparency, accountability, and good governance on pharmaceuticals. Let me just say that the policy was set up in 2012, and we envisioned that it would guide the process over a 10-year period. And last year, we embarked on a process of its review, where we've actually done a situation analysis that we'll be able to publish very soon to say how effective have we been in implementing it. Next slide. Now, when you look at the National Pharmaceutical Services units, in Kenya, we have 4 main units that are responsible for governing pharmaceutical services. We have the Pharmacy and Poisons Board, and this really is the regulator. It regulates both the pharmacy profession, the manufacture, and the trade of all medicines within the country. Very closely associated with it is the National Quality Control Laboratory that is really responsible and is established under the same act as the Pharmacy and Poisons Board. It is responsible for assurance of medical substances and drugs, and indeed all other health products and technologies. Then we have the Kenya Medical Supplies Authority. The Kenya Medical Supplies Authority has been established legally with a mandate to procure, to store, and to distribute all health products and technologies. Now, all these 3 National Pharmaceutical Service units are stewarded by the Directorate of Health Products and Technologies that was established through the Health Act of 2017, and that sits in the headquarters of the Ministry of Health. Next slide, please. Next slide. Now, therefore, we have 4 National Pharmaceutical Service units. Right now, the oversight, as I had indicated, is under the Directorate of Health Products and Technologies, but we've got the Pharmacy and Poisons Board, which is the regulator, the National Quality and Control Laboratory, which oversees issues of quality assurance, and the Kenya Medical Supplies Authority, which oversees procurement, warehousing, and distribution of HPTs. 2 of these bodies, or let me say specifically, the Kenya Medical Supplies Authority is established as an autonomous body, whereas the National Quality Control Laboratory and the Pharmacy and Poisons Board are still semi-autonomous. They still operate as government agencies, but we are working towards ensuring that they acquire autonomy. Next slide. So what have been our challenges? One of the challenges, and I believe any country will be able to experience when they establish National Pharmaceutical Service units, is the fact that the more independent the units are, sometimes the less the data and information that is shared among them. That has sort of like proved as a challenge that requires to be overcome. A second key challenge has been on the issue of human resource to manage the operation and the finances that are required to manage the various operations that are there. You can never really have sufficient budget allocation for services, and especially when you have more pharmaceutical service units, each of them will be having an independent budget that will require both human resource and finances to be done. As I said earlier, another big challenge that we've been experiencing is on the issue of supply chain, and I'll just put it into context. The purpose for us having the Kenya Medical Supplies Agency operating as an autonomous body, it is envisioned that through the work that they do, they'll be able to get sufficient financial resources as a result of service delivery. But we do find that when you have about 47 counties that are drawing from the same kitty, then you'll have an issue of delayed payments. And that has really been a challenge for us with the Kenya Medical Supplies Agency. We have also realized that once these HPTs go out to the counties, then we have possibly not had adequate storage structures in place at the county level, and sometimes even at the institution level, to ensure product availability is there. And therefore, a few years ago, we decided to ensure that the Kenya Medical Supplies Agency does what we call a last mile delivery, where it delivers to the smallest healthcare unit within the country with some limited success, with some significant success, because then it allowed us not to invest a lot into storage structures at various levels. Next slide. Next slide, please. Now, what is working well for us? I believe one of the things that we're very proud of in Kenya today is the fact that as a result of the Kenya National Pharmaceutical Policy that guides policy, we have been able to develop a HPT supply chain strategy. We developed in the year 2020, around about the time of COVID, and we envision that it will take us through a period of about 5 or 6 years. Now, this has been a very important document for us at the Ministry of Health and also for all other National Pharmaceutical Service units, because it was a very comprehensive review that has everything, including the costing of providing various services. This has actually been able to guide the country very, very well. We are midway through its implementation, and we've just done a midterm review to see what else we need to do. The other thing that has been very good for us is having the guidelines and the commodity lists that are able to guide us on what to do. We have been able to set up the Kenya National Formulary 2023, the Kenya Essential Medicines List 2023, the Kenya Essential Medical Supplies List 2023, and also the Kenya Essential Diagnostic List 2023. And these are very useful in guiding us what we do. On the issue of the Pharmacy and Poisons Board, we have really improved on data automation so that all the services that are offered by the regulator can be accessed automatically and online. And we are already on a path to ensure that we attain regulatory maturity level 3. We are also working very well between the various NPSUs and other institutions and donors and implementing partners to be able to work together. And we are very happy about the collaboration we've had, especially with the implementing agencies within the country that have come to help the various NPSUs within the country. Next slide. I think that was my final slide.
Thank you so
much.
Thank
you very much. And back to you, Andrew.
Dr. Menge, thank you so much. I mean, a great whirlwind tour of what's happening in Kenya. So we want our folk online just to keep that in mind. If you have particular questions you'd like to direct to Dr. Menge, then please type those in the chat. We'll come back to questions. We're now going to move to Côte d'Ivoire. But before we do that, I'd just like to remind you that we do have interpretation, and we'd like to invite you to move to the bottom middle of the screen. So on the very bottom, you will see that there is a world. If you click on that, you will note that you have the opportunity for either English or French language stream. Please choose the language of your choice so that you're able to hear through interpretation. Professor Amari, can I confirm that you're online and that your microphone's working okay, please?
Yes, good morning. I am online.
Perfect. So I would like to give the floor to you. You have 8 minutes. The floor is yours. Thank you so much.
Okay, my English is not so good, so I will make my presentation in French, please.
Merci beaucoup.
D'accord. Donc, merci beaucoup pour cette opportunité. Prochaine diapo. Next slide. OK. Donc, en Côte d'Ivoire, concernant le secteur pharmaceutique, il faut donc indiquer que le ministère de la Santé joue un rôle central. Et ce ministère de la Santé a développé plusieurs politiques dans le secteur de la santé, dont une politique pharmaceutique nationale, donc qui a été récemment révisée. Et à cette politique pharmaceutique nationale, il y a un plan stratégique pour l'accès aux médicaments qui a aussi été développé. Donc, la politique pharmaceutique nationale montre tous les aspects du secteur pharmaceutique, toute la chaîne de valeur du médicament à développer. Diapo suivante. Next slide. OK, donc, il y a eu donc en 2015 essentiellement de nouvelles lois sur le secteur pharmaceutique et le gouvernement a décidé de réformer le secteur pharmaceutique, notamment avec l'instauration de ce qu'on appelle l'autorité ivoirienne de régulation pharmaceutique, qui a remplacé la direction de la pharmacie et du médicament, qui est donc désormais le régulateur du médicament en Côte d'Ivoire. C'est une structure qui est un établissement public, mais dont on a renforcé les capacités de régulation en conformité avec la loi type de l'Union africaine qui a été adoptée en 1996 par l'Union africaine et qui voulait des autorités de régulation pharmaceutique fortes et autonomes. Donc, sur cette logique, la Côte d'Ivoire a été pratiquement le premier pays francophone d'Afrique occidentale à ériger un régulateur pharmaceutique qui est l'Autorité ivoirienne de régulation pharmaceutique. À côté de cela, bien sûr, il y a l'Ordre national des pharmaciens, traditionnellement, qui s'occupe de l'éthique et de la déontologie. Et puis, nous avons aussi la réforme a abouti au niveau de la chaîne du médicament, au changement de statut de la pharmacie de la santé publique, qui est devenue maintenant la nouvelle pharmacie de la santé publique, qui relève donc du droit public, puisque c'est une association, mais qui a des prérogatives quand même de puissance publique, puisque l'État lui a concédé la fourniture des médicaments dans le secteur public. À côté de ça, il y a toujours bien sûr le ministère de la Santé qui a un rôle de contrôle, avec notamment une direction de l'activité pharmaceutique qui existe à côté du Laboratoire national de santé publique, tout cela qui est chapeauté par la Direction générale de la santé. Donc, la réforme a abouti à l'instauration d'un régulateur pharmaceutique, aux attributions renforcées, à l'indépendance renforcée et également à une centrale d'achat qui relève du secteur privé avec une concession pour la fourniture des médicaments dans le secteur public. Diapo suivante. Diapo. Next slide. Alors, voilà donc comment se présente l'évolution, n'est-ce pas, sur le plan réglementaire des textes qui ont donc abouti à avoir cet écosystème, ce paysage de la régulation du secteur pharmaceutique en Côte d'Ivoire. Depuis 2017, donc, nous avons le régulateur qui est l'AIRP, Autorité de régulation pharmaceutique, et puis le Laboratoire national de santé publique qui existe, hein, par un décret depuis l'année 2009. Et puis, bien sûr, nous avons euh, la NPSP, qui est donc la centrale d'achat dont je venais de parler, avec son changement de statut. Et puis, une direction qui existe toujours au ministère de la Santé, qui s'occupe des activités pharmaceutiques, qui est née sur les cendres de l'ancienne DPML et qui est la direction de l'activité pharmaceutique, qui a des attributions en ce qui concerne l'évaluation des besoins en médicaments et la chaîne de valeur du médicament, la chaîne d'approvisionnement en médicaments. Et bien sûr, l'Ordre national des pharmaciens qui a le rôle de contrôler l'éthique et la déontologie dans l'exercice de la profession pharmaceutique. Diapo suivante. Next slide. Next slide. OK, donc quels sont les principaux défis, hein, auxquels nous sommes confrontés? Bien sûr, c'est un défi en termes de capacité, en en termes de capacité à réguler correctement le médicament, un défi en termes de financement des organes chargés de mettre en œuvre la politique pharmaceutique, qu'il s'agisse au plan des ressources humaines, au plan du renforcement des capacités, au plan, n'est-ce pas, de l'inspection des établissements, au plan de la régulation en général du secteur pharmaceutique. Le défi aussi, c'est la conjugaison intelligente des attributions des différentes structures qui interviennent dans le cadre de la régulation, parce qu'on constate quelquefois sur le terrain des incompréhensions ou même peut-être qui s'apparentent à des chevauchements d'attributions et sur le terrain, ça crée quelques difficultés. Donc, il faut mettre en place une concertation intelligente des différents acteurs pour obtenir les objectifs qui sont fixés au plan de la santé publique. Diapo suivante, s'il vous plaît. Voilà, donc je pense qu'aujourd'hui, le secteur pharmaceutique en Côte d'Ivoire est un secteur qui est vraiment bon, on ne peut pas dire performant à 100%, mais qui est très animé. Il y a des industries qui commencent à s'installer avec les nouvelles lois. Il y a une zone franche à Bassam. On est passé de quelques industries seulement il y a quelques années à plusieurs licences. Donc, il y a l'autorité de régulation pharmaceutique qui existe, qui est chargée donc de donner les attributions et puis de réguler la pratique de la médecine sur le terrain avec une évaluation une accélération normalement des procédures. Et puis donc, je pense que l'industrialisation demeure un enjeu fondamental au niveau de la Côte d'Ivoire par rapport au développement du secteur pharmaceutique. Et le ministère ne cesse de mener des actions pour essayer d'attirer les investisseurs et puis les amener à développer la production locale des médicaments, les médicaments génériques, le reconditionnement des médicaments, la facilitation de l'obtention des AMM, etc., etc. Donc, diapo suivante. Diapo suivante. Bon, il y a aussi la préqualification qui n'est pas encore obtenue au niveau du labo national, oui. Donc, l'assurance qualité, l'assurance... Bon, c'est bon, on peut passer à la diapo suivante. On peut passer à la diapo suivante. L'assurance qualité des médicaments est assurée par le laboratoire national, essentiellement au niveau de la demande d'AMM, puisque systématiquement, toutes les demandes d'AMM sont accompagnées d'un contrôle de qualité qui est demandé au laboratoire national et le médicament n'obtient l'AMM que sur le contrôle de qualité performant au niveau du laboratoire national. Le contrôle systématique à l'importation est exercé au niveau de la NPSP, mais n'est pas encore généralisé au niveau des importateurs privés. Ça aussi, c'est un challenge qu'il faudra pouvoir réaliser. Diapo suivante. Next
Merci
slide.
beaucoup, Professor Amari.
Ah, OK, d'accord. Merci beaucoup. Thank you very much.
Yeah, Professor Amari, merci beaucoup. Thank you very much for your, again, very quick and to the point presentation. What's interesting is comparing and contrasting what's happening in Côte d'Ivoire with what's happening in Kenya. It's very clear that there are two very different structures. It's clear that some of the issues to do with capacity and resources are similar. It's also interesting to see how the mandates for the different national pharmacy units are divided in those two countries. And so we would like to thank you very much for your presentation, and Dr. Menge for yours as well. The floor is open for questions, which we invite you to put in the chat. Just as those questions might be coming through, we'd like to ask all of you a question. And I'm going to hand over to Alicia, who's going to launch a Zoom poll for us to see where you stand with some of these issues. So she's launched the poll, fantastic. So what do you see as the greatest challenge in pharmaceutical sister governments where you work? And choose one of the answers listed on the screen. We'd like to invite as many of you as possible to choose your answer by selecting the button on the left that corresponds to your best answer, and then click submit. And so please do that now. Let's check the chat to see if there's any questions coming through. There's none at the moment. And so we're going to count down 10 more seconds for you to place your vote for our poll. What do you see as the greatest challenge in pharmaceutical system governments where you work? 5, 4, 3, 2, and 1. We're going to close the poll, and then we're going to ask Alicia to share the answers. Very interesting. You can see how you fared on the screen, quite even actually across, with the lack of communication coming out on top with 35%. And it is interesting that as an audience, the particular issues that you are sharing with us are not too dissimilar to some of the issues that were presented in the two case studies that we've heard about today. So thank you so much. We're going to have another poll for you at the end. So for those of you who have come on since we've started, very welcome. You've reached the webinar where we are talking about national pharmaceutical units, key aspects of governance associated with the availability and use of quality medicines. So far, we've had an introduction to the methodology we've used in MTaPS to look at this particular area. We've had 2 case studies, which shows some preliminary results from the country of Kenya and Côte d'Ivoire. And then we're now going to go into a more interactive panel And I'd like to invite the next slide, please. And we're going to just dive a little bit deeper with 4 panelists. We're going to bring Dr. Menge back on, Professor Amari, Dr. Kusu, and Herodias for some questions. I'd like to invite each of our panelists to put their video on, and then I would like to ask Alicia if she can show the videos of all of our speakers and myself for others to see. And we're going to go on a little journey together. And there's always lots of different ways to do this. And as we go through this today, as participants listening, and as you generate questions, please put them in the chat. And at the end of this 20 minutes worth of questions, we're going to have a look at things. So first of all, Dr. Menge, I'd like to ask you a question. You have reflected on your NPSU structure, the roles, the responsibilities. What would you say is one area where you're having greatest impact with regard to medicine's availability of use? Dr. Menge, I'm interested in your perspective on this. Where are you having greatest impact?
Yeah, I think Kenya is going through a very interesting phase where we had to completely relook at the way we do service delivery. And for us, we decided that one of the ways that we're going to impact service delivery and also the supply of not just pharmaceutical products, but also other health commodities, is to give a governance structure that we expect to be followed both at the national level and also at the county level. And therefore, we came with a proposal to have what we call health, product, and technology units that went all the way to legislation. And that sort of like gives predictability on how we function at every level. And therefore, the work that I do at the national level is to, first of all, find out how can we be able to regulate all that. The other thing that has been quite impactful is having regular communication and visibility of what is happening at every level of service provision. And we do this through, first of all, looking at tracer items that can be able to give us a guidance on that. And apart from that, we have really committed ourselves to ensuring that we have the best documents that every single person can be able to refer to. And I refer to the essential lists and also the national formulary that has had a great impact on service delivery. Thank you, Andrew.
Thank you so much. The first part of your answer made my heart sing. A government that sees a priority in governance to legislate structures down to the county level. This makes me so happy as a pharmacist involved in governance. Professor Amari, I would like to bring you into the conversation at this point. Can I ask you, as you reflect on the NPSU structure and roles and responsibilities in Côte d'Ivoire, what's one area where you're having the greatest impact on medicine's availability or use? Professor Amari?
Yes, I said my English is not so
You're welcome
good.
to use French.
Yes, but I have to understand the question before talking in French.
So let me mention to you just now, if you go to the bottom of your screen, you can choose the globe and choose the French interpretation. Can you see the icon? Otherwise, I'll ask Herodias just to repeat the question. Thank you, Herodias. Or Lauren, could I just ask you to please repeat the question, Lauren? Thank you.
Herodias, ton micro est fermé.
Oui, Herodias, ton micro est fermé.
Yeah. Okay, so Lauren, if you could just repeat the question, that would be great.
Apologies, I didn't catch the question, but Professor Amari, est-ce que tu vois l'option d'interprétation? Si vous allez en bas, vous pouvez cliquer, il y a l'option d'interprétation et vous pouvez sélectionner français.
En bas où? Où ils ont mis plus là?
Oui.
Okay, so let's continue together.
Et
So
je
we'll come
clique
back,
sur quoi, anglais
Professor
ou français?
Amari. Yeah,
J'ai
we'll come
anglais
back
et
to
j'ai
you
français.
shortly. Yeah.
Je clique sur
My-
français ou anglais?
Yeah, sorry, yeah, folks, for the
Français.
technology interruption.
Clique sur français. OK.
Yeah.
Ouais, je vous reçois.
So
Professor
Professor
Amari
Amari,
is now following in the
Oui, je reçois.
interpretation room.
okay, great. Okay, so
Oui, je reçois l'interprétation.
Professor Amari, I
Oui.
would like to just quickly ask you,
Oui.
as you reflect on
Oui.
your presentation you've just given, what would you say is the one area where you've had greatest impact? What's one thing you've done to have greatest impact in medicine's availability? What's the one big thing? And
Moi, personnellement, vous voulez dire?
from your
Alors,
department's
en
perspective,
ce qui me
the
concerne, je
oversight role
pense
that you
que
play.
c'est l'évolution de la réglementation. Nous avons joué un rôle très important dans la révision des textes dans le secteur pharmaceutique. Et ça, c'est très important. Donc, à partir du moment où, en 2016, les États membres de l'Union africaine ont adopté la loi type de l'Union africaine pour la réglementation des produits médicaux, nous avons sauté sur l'occasion pour instaurer en Côte d'Ivoire l'autorité ivoirienne de régulation pharmaceutique, qui est un organe indépendant en matière de régulation, là où, dans l'ancien régime, il n'y avait que la direction de la pharmacie et du médicament, qui n'était qu'une direction du ministère de la Santé. Donc aujourd'hui, on a un organe indépendant, à l'image de beaucoup de pays anglophones, qui est chargé de réguler le secteur pharmaceutique. Il a une indépendance technique, il a une indépendance de gestion, et ça lui donne plus d'autonomie pour impacter la régulation du secteur pharmaceutique. Et puis, à cause de ça, il y a eu la révision de plusieurs textes, notamment les textes de la nouvelle pharmacie de la santé publique, qui a aussi augmenté en autonomie technique de gestion et qui permet quand même aujourd'hui au système pharmaceutique en Côte d'Ivoire d'être plus performant. Donc, je pense que la révision des textes et la révision du cadre institutionnel a été un élément fondamental dans notre action. Merci.
Yeah, and I appreciate you emphasizing that, because this overarching legal framework or structure is a key enabler for other actions to happen in country. So thank you for that answer. We have two others on our panel. We have Dr. Kusu, and then we also have Herodias. They represent MTaPS in the respective countries of Kenya and Côte d'Ivoire. And we've been working in partnership with country governments. And I'd like to ask you, Kusu, that from a project perspective, what's one area you've observed where you've needed to adapt or improve with regards to pharmaceutical systems governance? Thanks, Kusu.
Thank you, Andrew, and thanks to the presenters this morning or this afternoon. For me, one of the areas I would want us to improve on is really matching access, with quality, safety, and appropriate use, of the health products and technologies. That's one quick area. But I'm also looking at really focusing, mobilizing resources, lobbying for pharmaceutical services and care, towards the patient-centered care, where, we are moving beyond the availability to looking at accountability, the safety, the rational use, the safety monitoring, and even going deeper, to provide, more enhanced pharmaceutical services for better health outcomes. Over. Back to
Kusu,
you.
a model answer, and I hope that this adaptation and this vision you have can come to fruition, because as we saw in the system strengthening pathway, it's just not having those medicines available. It's making sure when they get to the facilities that they're used appropriately, not only of quality and used appropriately. And governance effects through that whole pharmaceutical systems pathway. So thank you for that. Herodias, working in West Africa, it's a different political environment. There are different systems and procedures. May I ask you to come in at this point, and from your work in the last few years, what's one area where you think we need to adapt or change in regard to pharmaceutical systems governance? Herodias?
Merci beaucoup pour la question. Pour ce qui me concerne, je travaille donc au niveau de MTaPS sur la problématique de la résistance aux antimicrobiens. Et à ce niveau-là, c'est au niveau des ressources humaines, en particulier pour la coordination multisectorielle, où j'ai dû vraiment m'adapter parce que pour la résistance aux antimicrobiens, la stratégie recommandée, c'est une approche, une seule santé. Et emmener toutes ces ressources humaines à regarder dans la même direction et pouvoir mener le programme à bien, les emmener à collaborer, alors qu'ils ont l'habitude de travailler chacun dans leur secteur, c'est ça qui a été un défi au démarrage et même qui continue. Beaucoup de choses ont été adressées, mais au niveau ressources humaines, il a fallu vraiment faire des efforts et en particulier ceux du secteur de la santé animale qui ont dû collaborer, le secteur humain aussi, en toute transparence pour partager les informations et permettre au secteur qui était en retard de pouvoir avancer parce que à la fin de la journée, l'évaluation, elle se fait sur tout le programme et non secteur par secteur. Merci beaucoup.
Herodias, thank you for selecting that topic, because one of the things that we don't often think about is that medicine's use, particularly antibiotics, and trying to reduce antimicrobial resistance, it's not just a Ministry of Health issue. It's also Ministry of Agriculture, Ministry of Fisheries. It's also issues to do with finance and public health. And often within the conversation of pharmaceutical governance, we can restrict our thinking and approach to Ministry of Health only. And so thank you so much for that. Professor Amari, I'd like to come back to you, please, sir. So you've been working with development partners for a long time, and you've obviously gone through a period of reform over the recent years with regards to national pharmaceutical units. On the call today, we have many people from many countries around the world. What's one piece of advice that you would give to a government that is going to embark on a journey to improve pharmaceutical systems governance? One piece of advice you'd like to give to a government that's about to embark on a journey to improve pharmaceutical systems governance? Professor Amari, the floor is yours. I just invite you to unmute your microphone.
Oui, mon micro était fermé, excusez-moi. Je pense qu'il faut mettre un accent sur les spécificités du pays d'une part et tenir compte de l'évolution de la réglementation pharmaceutique d'autre part. Parce que ce qui est au centre du système pharmaceutique, c'est le médicament. Et le médicament est un produit qui n'a pas de frontières. Donc, nul ne peut agir en autarcie. Par contre, la nature des spécificités locales est très importante. Ce qui existe en Côte d'Ivoire n'est pas forcément ce qui existe au Kenya ou en Afrique du Sud ou à Paris. Donc, il faut faire un état des lieux sans complaisance de la situation locale et il faut tenir compte des orientations internationales et sous-régionales en la matière. En Afrique de l'Ouest, pour prendre cet exemple, nous avons l'UEMOA qui émet beaucoup de réglementations pharmaceutiques et même la CEDEAO. Donc, les États sont soit des États membres de l'UEMOA, soit des États membres de la CEDEAO, en tout cas des États membres de l'Union africaine. Donc, chaque pays prend en compte sa politique pharmaceutique nationale, mais elle considère sa politique pharmaceutique nationale en tenant compte des orientations de la sous-région et des orientations internationales. Un gouvernement qui veut réguler, qui veut réviser sa réglementation, devra tenir compte de ses réalités propres, mais aussi des grandes orientations sous-régionales, régionales et même internationales. Merci.
Thank you for that. And I think that is very important. We're respecting the sovereignty of countries. If we're using an American phrase, We don't have any cookie cutter approach. We're looking at understanding the context. Dr. Menge, I'd like to come to you and build off this answer. One of the interesting things that many countries are watching in Kenya is how the devolution unfolds, how the quality of pharmaceutical services delivery can be maintained when you effectively have 52 governments looking after things, or 47. And I would like to give you the floor just to build on this so far. What would your recommendation be to country governments seeking to improve pharmaceutical assistance governance? The floor is yours.
Thank you, Andrew, and thanks for highlighting a challenge that we experience in trying to ensure that there is equity in service delivery of our 47 governments that are really supposed to offer health health services independently. And I just highlight one of the challenges that we've experienced is that when you've got very many governments that are offering the same service, then you start having disparity. They are quick adopters, they are slow adopters. But what could I advise a government that needs to go the direction of setting up the national pharmaceutical service units is we do not need to really reinvent. We have very good models, and I saw one of the people asked us, what did we find out in Nepal, and how can we be able to, is it something that is going to be disseminated? One of the things that I really want to say is that let's look around at the various models. I've listened to Professor Murray today, and he's talked about the model they've adapted in Côte d'Ivoire, and there are things that you can be able to borrow from. And therefore, my simple answer would be, please don't go to the beginning and trying to invent it. Just find out what the others have done and seek to pick best practice from those countries.
Thank you so much. And I'll tell everyone that I didn't ask Dr. Menge to say that. I didn't pay him any money to say that. But at the end of this talk, we're going to talk about some guidance. And in reference to the question about Nepal, that is to mention that in addition to Kenya and Côte d'Ivoire, we also did some work in Nepal, and the overall report and publications that we will make available will be showcasing those 3 countries as well as some of the other guidance. So thank you for that. And it's quite exciting to learn from others in terms of that. Okay, let's go to our last round of questions to Herodias, first of all. So Herodias, MTaPS has been operating now for more than 5 years. And is there one area of success in pharmaceutical assistance governance that you'd be able to focus on? And as we go into the next generation of improvements, what's one area that needs additional investment? So one particular area you've seen a success in your work, and one area that you still think needs investment. Herodias, the floor is yours.
Donc, merci beaucoup. Déjà, pour les domaines de succès, tout à l'heure, j'ai parlé de tout ce qui concerne la gouvernance de la RAM, où des unités multisectorielles ont été mises en place pour pouvoir faire évoluer le programme. Beaucoup de choses en matière d'organisation, tous les aspects liés à la régulation, la réglementation et tout ça, qui ont été faits, ce sont des succès. Mais il faut maintenant, en matière d'organisation même du système, pouvoir accroître la participation du secteur privé et de la société civile dans les activités pour qu'on ait un impact qui soit plus grand. Le domaine dans lequel je me dis qu'on a besoin d'investissements supplémentaires, c'est au niveau de la gestion des antimicrobiens où on a pas mal de difficultés dans le secteur de la réglementation qui souvent existe, mais qui n'est pas appliquée. Les problèmes liés à la communication de masse pour induire un changement de population, parce que tant que les populations continueront à aller faire des demandes d'antibiotiques dans les officines, on ne va pas évoluer sur la question. Au niveau donc du cadre réglementaire, il faut, à mon avis, avoir un cadre réglementaire qui soit beaucoup plus contraignant maintenant pour amener les gens à mettre en pratique ce qui a été recommandé. On a restructuré tout le secteur pharmaceutique, mais si on ne met pas une réglementation qui est beaucoup plus contraignante, on va rester dans le même système. Il faut aussi mettre, à mon avis, l'accent sur la disponibilité de ressources humaines qui soient performantes. J'étais hier dans un établissement de santé pour une supervision et le directeur de l'hôpital, la question qui se posait, c'était de savoir s'il avait des ressources humaines à sa disposition, qui avaient les compétences nécessaires pour lui permettre d'atteindre ses objectifs. Donc, à mon avis, il faut tout ça et aussi améliorer tout ce qui concerne la gestion de données, mise à disposition dans le cadre de l'information sanitaire pour que les gens puissent s'appuyer sur ces informations et prendre les décisions qu'il faut pour améliorer le secteur pharmaceutique. Je vous remercie.
Alright, thank you so much. Quite a comprehensive answer. And for the donors listening out there, obviously we need more investment in pharmaceutical services and particularly governance. And you've given us some great thoughts. Kusu, let me come to you with the same question. Again, you have many, many years of experience, and particularly in MTaPS, the last nearly 6 years. What's a particular area of success? And as you look to the future, where do we need more investment? Thanks, Kusu.
Yeah, thank you, Andrew. I think one of the areas that we've been successful is really supporting governance across board, establishing the governance structures, even supporting, development of the related costed work plans. And this has been in support of containment of antimicrobial resistance. But then also when I look at the, our pharmaceutical governance, again, as Dr. Menge had mentioned, supporting the government to develop the first Kenya National Medicines Formulary 2023. And we were also able to really to review the Kenya Essential Medicine lists 2019 and 2023, again, to ensure that there is a aware categorization to, reserve and promote prudent use of antimicrobials. But what's important to note for Kenya is that those lists, the lists and the formulary are contributing towards universal health coverage. And we have commitment, even from the president, where 50% of the items within the KML should be, locally manufactured by 2026. Then looking into the future, Andrew, I see the need to really invest more in supporting the regulatory systems to ensure that, countries can attain maturity level 3 status, but then they can also be able to assure their citizens of, quality, efficacious, safe, essential medicines and other, other products. And the investment should go, towards all the regulatory functions and including, the institutional and the human resource, capacities. Over.
Kusu, thank you so much for bringing us back to the patients. After all, pharmaceutical systems, if we're not making medicine, quality medicine available for use for the women, the children, the mums, the dads, the grandmas, the aunties in the villages, then we're really wasting our time. And I think that focus on ultimately what are we doing to improve that for those people is a great place just to end this part of the panel before we go to questions. So please, folks, if you want to choose an icon at the bottom of the screen, you'll see it says reactions. Choose something to encourage our panelists. I'm going to choose some streamers and then also a love heart to say thank you so much to that. So we've got time for a round of questions. Those questions have been coming fast and furious in the chat. What I'd like to do is to give each of the panelists one question. So if you listen carefully, I'm going to go through question one at a time, and then I'll get you to respond. So Professor Amari, the question for you is the National Quality Control Laboratory certified by WHO or ISO 17025? So just a moment, hold your answer. Dr. Menge, I'd like to, it's a two-part answer. What are the challenges encountered in changing the status of a central procurement and supply agency towards autonomy? What was the resistance? If you were part of that decision or you're aware of the history of how KEMSA came to be an independent authority, what was the particular issues around that? And maybe Kusu, you might want to add to that after Dr. Menge. Herodias, for yourself, as we think about antimicrobial stewardship, the question is, I'd like to know about the harmonization in the human and veterinary medicines policy management, especially when we're talking about the One Health approach. One issue is the use of antimicrobials in the different sectors. So the question is to do with the harmonization. How is the human and the veterinary section coming together for discussion? And then question 5, Lauren, I'm going to ask you to submit to Augustina to pick up as part of her presentation status. And with that, let's go to our panelists for answering this round of questions. Professor Amari, you're first.
Ma question, je n'avais pas la traduction, donc je n'ai pas bien compris ma question, hein. C'était quoi ma question, s'il vous plaît? Je n'avais pas la traduction, donc c'est maintenant que je l'ai eu.
Is the National Quality Control Laboratory in Côte d'Ivoire certified by the World Health Organization, or is it ISO certified?
OK. Alors, le laboratoire national était engagé dans le processus de préqualification de l'OMS. Ils ont déjà, mais en plus de la certification ISO, le laboratoire national s'est engagé dans le processus de préqualification de l'OMS. Donc, je pense que ce processus est encore en cours, hein, sauf erreur de ma part. Donc, il est certifié ISO et il est engagé dans le processus de préqualification de l'OMS, qui est en cours.
Thank you. Thank you so much. Dr. Menge, your question?
Kindly confirm that the question I'm talking about were the challenges encountered in changing the status.
Yes, so the challenges encountered with the transfer of status from KEMSA being part of the Ministry of Health to becoming an independent entity. Was there resistance from the Ministry of Health, losing that power?
Yeah, so Andrew, first of all, it's a very unfair question because I work for the Ministry of Health. So I'm being asked to say, do we oppose KEMSA being independent? But basically what we did, it has been a journey. It's been a very long journey. And the most important element, I think, is to have the governance structure and allow it to have a human resource that is independent. It is a bit challenging because many times, as much as we've created autonomy in it, it remains a government agency and therefore retains some kind of oversight. The government will retain, or the Ministry of Health will retain some oversight on its activities. But we allow KEMSA to operate with an independent board that constitutes of close to 80% independent members, and we only have 2 representations from government in that board to show the interests of the government. But yes, I'll just say that it is a journey, and many times as government, we have to come in and possibly address 1 or 2 things. I don't think that's opposition, it is facilitation to make sure that the direction that KEMSA is taking is in agreement with the changes that we have in government policies. Thank you.
Yeah, thank you so much for that. Kusu, anything you'd like to add to that or any of the other questions before we move on to Herodias?
Yeah, thank you, Andrew. Dr. Menke has tackled it very well. I think the only addition is that, you know, by having a KEMSA law, an act in place in Kenya, that enabled quite a number of the changes to be done. Thanks, and back to you.
Thank you so much. And again, we come back to the importance of these legal structures that need to be in place to underpin or to have the oversight for these structures. And Herodias, let's come back to you with the final answer to do with the human and veterinarian harmonization. Thank you, Herodias.
Merci encore pour la question. Donc, en termes d'harmonisation, j'ai vu dans le détail de la question qui m'a été posée qu'on voulait savoir comment est-ce qu'on a réussi à amener le secteur vétérinaire et le secteur humain à collaborer, travailler en synergie. Donc, la première étape a consisté d'abord à créer un comité multisectoriel technique qui a une unité opérationnelle et les emmener donc à travailler ensemble. Donc, les différents secteurs qui sont concernés sont membres de cette structure. Donc, déjà, ils commencent avec des réunions de coordination, une planification commune. Donc, ils ont élaboré un plan d'action qui prend les différents volets en compte. Et puis, à partir de là, aussi, tout à l'heure, quand je parlais des succès, je dis qu'il a fallu faire un partage d'expériences et d'informations de manière transparente entre les secteurs. Donc, le secteur de la santé animale a dû mettre des activités qui ne sont pas des activités auxquelles ils sont habitués. Par exemple, dans le secteur de l'approvisionnement, ils ont appris, donc, le secteur humain à partager son expérience avec le secteur animal pour les emmener à mieux suivre la planification des approvisionnements et puis réaliser des cartographies des approvisionnements, ce à quoi ils n'étaient pas obligés. Donc, ils ont dû faire preuve de beaucoup de flexibilité pour pouvoir intégrer tout ça dans leur système. Donc, c'est vraiment déjà à travers le comité multisectoriel de coordination qu'il y a des réunions qui se tiennent chaque 2 mois qu'on les a amenés d'abord à se fréquenter, à mettre leur plan ensemble et puis pouvoir en faire la mise en œuvre. Je vous remercie.
Thank you so much. So again, a governance structure which are bringing people together with a common purpose to get results, and in this situation with your AMR. So thank you. So thank you very much to our panelists for giving us those insights. And I invite you as our panelists just to look, there are still some further questions in the chat we didn't get to. And if you're able to respond in the chat in French or English to any of those questions, that would be very helpful. Next slide, please. So you've all been waiting very patiently. We've understood the problem, we've heard the case studies, and now we're going to go back to Dr. Augustina, who's going to share with us some of the guidance that we have gleaned from looking at these case studies and looking at this literature. Dr. Augustina, the floor is yours. Thank you.
Thank you so much, Andrew. And thank you all panelists for the interesting discussion. So before I go on, there was one question in the chat, if I can address that briefly before we move on. So it talked about how national regulatory authorities and central medical stores can work in agreement without compromising on qualities of medicines. So based on the literature and also from country case studies, the central medical stores work hand in hand with national regulatory authorities in the sense that before procurement is done, and I think one of the panelists talked about it, medicines from essential medicines list are things that are stocked at national level and procured. So, and 2, medicines that are registered in country. So for example, the essential medicines list, medicines registered by the national regulatory body in a way as to guide the central medical stores and what they can procure. One other way that they are able to work together is during tendering. So in their procurement processes, representatives from national regulatory authorities are part of the panel or individuals who will go through the tendering processes. And samples of products are sent to the National Regulatory Authority for quality control issues. So these are some of the ways that central medical stores and national regulatory authorities can work to ensure that we have safe, effective medicines. Okay,
Thank you so much, Augustina. That's a great answer. Just to let you know that we have an adjusted time of about 12 minutes for you this last section. Thank you so much.
I'll go quickly. Thank you. So what we've discussed so far, we are looking at guidance. We have realized from all the discussions that there are 3 main functions. So medicine regulation, procurement, distribution, and storage. And we talked about pharmaceutical policies, so selection, rational use of medicines. We've looked at pharmacy practice and regulation, so the premises and regulation of the practice also. So what we are saying is that these national pharmaceutical units must be embedded within the pharmaceutical system. And we have seen this diagram from the beginning. So here we are focusing on all structures, people, resources, processes, and how all this interact within the broader health system to ensure that we have equitable, timely access to effective, safe, and quality medicines. Okay, so based on this, we can point to 3 main critical factors that pharmaceutical service units should have. And one, it will be a clear structure within the relevant Ministry of Health. Second will be a legal framework, legal or administrative. So is there an act of parliament or a law that seeks to give mandate to these national units to work? And within the ministry, there should be a clear unit that seeks to provide national pharmaceutical services. So these are 3 points that we have identified. So one of the recommendations is to have a high-level unit for policy governance, so pharmaceutical policy. So here, legal backing, that I will identify one unit that has the clear mandate to provide governance or stewardship when it comes to pharmaceutical policies and governance. So here, emphasis on coordination within the pharmaceutical system. So all the structures, the processes, the people, overall units that seeks to provide coordination and formulates national medicines policies, other strategies, and gives directions. So when it comes to selections of medicines, standard treatment guidelines, design, essential medicines use, and very importantly, how to monitor and evaluate pharmaceutical systems indicators. So access to medicines, use of medicines. It's very important to monitor and evaluate this moving forward. So what we are proposing is to have a unit with these functions, and the unit will have direct reports to the Minister of Health. And this is also very important because where the unit is structured gives them opportunity to be involved in decision-making at high level and also allocation of resources. So this is one unit that we are proposing, overall governance stewardship for policy design and also implementation and also monitoring. The second will be having a unit. So based on the discussions we've had so far, national regulatory authorities seems to be semi-autonomous agencies of the ministry. So what we are recommending here is not new. There's already consensus as to the functions of national regulatory authorities. There should be a clear mandate, again, legal or administrative framework that gives them authority to regulate medical products through the product life cycle, okay? And should be able to ensure quality, safe, and efficacy of medical products. We have stated functions here, and these are already known functions. So again, because they are semi-autonomous, they have some flexibility when it comes to decision-making, when to hire people, and decisions around what to do and how to engage with other agencies. So this is also very important, and we have seen from the examples that most national regulatory authorities seem to be semi-autonomous and situated within the Ministry of Health. Next slide, please. So with our next recommendation, where we are looking at a national pharmaceutical unit with focus on procurement, supply, and storage, there again has to be a clear mandate. So a legal mandate that seeks to set this unit up. And if there are direct or indirect relationship with third-party logistics providers. So in some settings, you have a central medical store, but some functions are being done by private providers. So for example, you find situations where you have storage being done by private providers or distribution. But whether this is done by government or by private providers, it's very important that there's a strong procurement supply chain system in place. Because if this is not the case, there's a possibility of substandard medicines or products will not get to our patients on time. So broadly, there should be supply chain strategic planning, logistics management, policies or guides, issues around quantification, procurement, and control of medicine prices, and of course, distribution and storage. Again, we recommend that such a unit is also high up in the organogram of the Ministry of Health, such that they are able to report directly to the Minister of Health and are able to participate in decision-making and also allocation of resources. Next slide, please. So the other recommendation, we've talked about medicine, national regulatory authorities. We've talked about having a unit that will give stewardship to policies within the pharmaceutical sector. There's one other national pharmaceutical unit, and this is the Pharmacy Practice Authority. So in some countries, you have Pharmacy Board, Pharmacy Council, a National Pharmacy Order, and they usually will have a legal framework that seeks to set them up. So they will regulate the practice of pharmacy and premises. In some countries, you have just regulating the premises without the practice. Okay. But here we are recommending that there is indeed an organization or a unit that has the role to regulate pharmacy practice and premises, and also the training of pharmacists. So the broad functions that we have identified here to regulate pharmacists, their practice, not only pharmacists, but also pharmaceutical support staff. They should also regulate the provision of pharmaceutical care, the premises, and also training. And this is very important because the provision of pharmaceutical care, how pharmacies are situated, has bearings on access to medicines, whether individuals, the general population will have access to medicine. Again, from literature and from our case studies, most of these pharmacy council or pharmacy boards are standalone, so semi-autonomous, and are a bit flexible when it comes to decision-making processes within such agencies. Next, please. So on this note, I hand over to Andrew. Thank you so much for your attention. Over to you, Andrew.
Dr. Augustina, thank you so much. There's some clear recommendations for us to think about, and all in the context of sovereignty of nations and about countries understanding their local context. So again, to be clear, in presenting these recommendations, it's recommendations and guidance that has come from the case studies and from the literature. And again, why? Because historically, the focus on pharmaceutical systems has moved away from this broader understanding of all of the aspects of pharmaceutical systems, and perhaps just focused a bit too much on supply chain and just regulation. But there is these areas of pharmacy practice, these areas of other aspects of pharmaceutical governance that need addressing if we are to make sure that there is quality medicines available. So thank you so much. A couple of next steps that I want to let you know about, which hopefully should keep you excited. We want you to reflect on the governance that we've spoken about today, and we want you to think about this in the context of availability and use. And what struck me about the particular case studies from Côte d'Ivoire and Kenya was how the legislation and the structures, both at the national and that county or district level, were in place in order to then act as that backbone for pharmaceutical governance to be effective. And we're encouraging all countries to think about their governance structures and what they might need to be able to do to improve those structures. Again, why? Because we want to improve the availability of quality medicines and the use of those medicines to all people in the countries where we live and work. For implementing partners on the call, we want to challenge you to reflect on the pharmaceutical system strengthening and the NPSU guidance as you consider activities to increase universal health coverage. Often in program delivery, whether it's HIV services, malaria, etc., the pharmaceutical systems and supply chain as part of that are not often thought about enough, both in resources and priority. So as you're thinking about your work plans and implementation, as you work alongside different entities in countries, let's think about what we can be doing to improve pharmaceutical systems. For donors, again, to those donors on the call, we thank you so much. And we join with others in the implementation sector to advocate for donors to thoughtfully include reference to pharmaceutical system strengthening and NPSU governance when planning for health-related products. Often what's in particular donor funding envelopes, there is guidance, and that guidance directs how money is spent. And we would like to encourage consideration of pharmaceutical system strengthening and pharmaceutical systems governance, particularly when you're thinking about health-related projects. No product, no program, absolutely, but no product, no quality product, and no real explanation on how it's used properly, no improved health outcomes. So we need to think about that. And for health and development professionals, which is nearly all of us, we need to be educating ourselves on pharmaceutical system strengthening and better equip ourselves for systems change so that we can all be working together for improved availability and use. We all have something we can do. Next slide, please. We're going to launch another poll. And this poll, Alicia is going to launch for us. And the question here is to what extent do you agree that the suggested guidance we've provided today would assist you to address your pharmaceutical systems governance priorities? To what extent? So we want you to think about, choose one of those buttons on the left, and then to click submit. And while that's coming through, Alicia, I'd like you to go to the final slide for us, please. So today, we've gone on a journey. You've come because you've been expecting information about national pharmaceutical systems units and governance. In our short time together, what we've tried to do is to put the problem statement out there that we think that focus on pharmaceutical systems outside of regulation and supply chain is under-focused, and we need to improve that focus. We've had great case studies from both Kenya and Côte d'Ivoire in this call. We've noted there's another case study we didn't highlight today from Nepal. We've shared with you a range of guidance principles on different structures and roles and how to think about that. And we've then given you a challenge about what you can do to go away and make those changes happen. On this screen, there's a range of resources. We will be publishing a technical report, which will have everything you've heard about today in detail, plus more, because the Nepal case study will be included. We have a free e-learning course and a governance course, and we have a technical brief and other tools which you can already utilize. And we would encourage you to go forward and utilize those tools in your area of practice. And Alicia, please launch the results of our closing poll. How much are we close to the mark? Okay, so agree or strongly agree, we're up there. And some people disagree. Yes, and it's quite fine to disagree. Perhaps it was a bit too brief for you, or perhaps you couldn't quite see the application. We would encourage you to access our more detailed information. In 90 minutes, it's quite difficult to give you all of the details, but we've hoped that as you leave this webinar today, you have a renewed understanding of the importance of pharmaceutical systems governance. You know where you can look in order to get more education and training for yourself and others around pharmaceutical systems and governance. And we also hope that you're waiting with anticipation for our published reports that will give you more information. With that, I would like to invite you to give a reaction to our panelists. I would like to thank Alicia and our interpreters and Lauren for their assistance. And as we depart and move on to our other duties today, I would encourage you to put your camera on and wave goodbye to your colleagues. Thank you so much for everyone from around the world who has joined us, and we wish you well in the rest of your journey today. Please, if you don't mind turning your camera on, it's great to see people's faces. We're not just avatars. although my wife thinks I'm an avatar because she only sees me on the computer occasionally. And we want to thank you all for your fantastic engagement with us.
Merci beaucoup.
Merci beaucoup. Merci, au revoir. And a particular thank to Professor Amari and Dr. Menge from your countries. And thank you, everyone. This has been an exciting webinar together. And for those colleagues that were unable to make it, this was being recorded. And Hazel, a shout out to you. We haven't spoken in ages, so good to see you. Thank you, everyone. We wish you well in your day today. See, now everyone just wants to hang out.
Au revoir.
Thank you, Kofi. Thank you, Professor Mari.